what the study says.
Imagine, if you will, having a contact lens that gives you high-definition vision. I'm talking arguably better than 20/20. You never have to take it out. You can't feel it. And here is the real kicker that separates it from almost every other surgical intervention. If you change your mind 10 years down the road, you can just have it removed. Is this sci-fi or the new standard of care?
Right. I mean, it sounds like the holy grail of ophthalmology. But let's apply a serious reality check right off the bat. We aren't talking about a contact lens that just sits on your eye. We are talking about surgery inside the anterior chamber, penetrating the eye itself.
Yeah, and that is exactly the tension we are exploring today. Is this sci-fi concept actually a safe standard of care? Or is it, marketing hype masking surgical risk? Today we are dissecting the massive data dumps on the EVO ICL, the Implantable Collamer Lens. Is it actually safer than taking a laser to your cornea?
That is the multi-million-dollar question. Welcome back to What the Study Says. I'm Dr. Kai.
And I'm Dr. May. Today's deep dive is into the nitty-gritty of that implantable Collamer lens, specifically the newer EVO models.
Right. And just to be super specific, we are looking at the V4C model, which is the one with the central port. Our mission today is to figure out if this additive surgery is a better bet than the traditional subtractive surgeries like LASIK or SMILE. And we're basing this strictly on recent peer-reviewed studies.
Yeah, we have a pretty serious stack of research today. We're talking about a study involving over 10,000 eyes. We've got specific U.S. retrospective data and some really heavy-hitting meta-analyses on safety. So let's just unpack this.
Let's start with the basics of the device itself, because implantable Collamer lens implies a lot of engineering. As described in the review by Wanapanic and colleagues, this is a phakic intraocular lens.
Phakic being the operative word there. We aren't stripping the engine to replace it like we do in cataract surgery. We are leaving the natural crystalline lens legally and physically in the building.
Exactly. The ICL sits in the posterior chamber. It's tucked right behind the iris and hovers just in front of your natural lens. It effectively corrects your vision from the inside.
And the material is key here. The studies make a really big deal about Collamer. It's a collagen copolymer. But why does that matter more than, say, standard acrylic?
Well, it really comes down to biocompatibility and charge. Collamer is hydrophilic, and it carries a slight negative ionic charge.
Which means it repels proteins.
Exactly. In the eye, protein deposition is the enemy. It creates haze, it creates inflammation. Collamer essentially makes the lens invisible to the body's immune system.
But the real revolution, and what really distinguishes the EVO models we are discussing today from the older ones, is the hole, the magic hole.
Right, scientifically known as the KS AquaPORT. It's a tiny 0.36 millimeter hole right in the center of the lens optic.
Which, on the surface, seems completely counterintuitive. I mean, I think most sophisticated listeners would assume that drilling a hole in the direct center of a lens would destroy the optics. You'd expect to see a permanent donut in your vision, or a floater. But the Luo and Wanapanic studies suggest that's just not the case. Why does this hole matter so much for the safety profile?
Because it solves the historical plumbing problem of phakic lenses. The eye is constantly producing aqueous humor that needs to flow from behind the iris, through the pupil, and into the anterior chamber to drain out through the trabecular meshwork. Older ICL models basically acted like a cork. They block that flow at the pupil.
Which is why we used to have to do an iridotomy, laser blasting a bypass tunnel through the iris tissue days before the main surgery.
Yeah, which is an extra surgical step. It adds significant inflammation, and it can cause issues like ghosting or bleeding. The Wanapanic data confirms that the central port allows for natural physiological flow straight through the lens itself. It completely eliminates the need for that peripheral iridotomy.
But more importantly, doesn't it address the cataract risk? Oh, absolutely. That is the critical physiological win. The natural lens has no blood supply. It gets all its glucose and oxygen from the aqueous fluid bathing it. By allowing that fluid to flow directly through the central port, you are maintaining the metabolic health of the crystalline lens. You aren't starving it.
Right. So the plumbing works. But let's get to the optical showdown, the battle of the eye surgeries, if you will. We have the ICL in one corner, and in the other, we have the reigning champion of corneal refraction SMILE. Small incision lenticule extraction.
This is where we have to look at the study by Luo and colleagues. This was a fascinating comparison because it looks specifically at high myopia, so patients with serious distance vision issues.
And the setup is classic. SMILE and LASIK are subtractive. They use a laser to basically vaporize or remove corneal tissue to reshape the curvature. Once that tissue is gone, it is gone forever. ICL is additive. you're putting something in.
And the LUO study followed these patients for 4 years, which is a really solid amount of time to see long-term stability and any regression. So what was the verdict on pure efficacy? Just reading the chart.
Safety and efficacy were statistically comparable. Both groups hovered right around 97% satisfaction. If you look purely at the Snellen chart, can they read the 20/20 line? Both groups performed exceptionally well.
But we know that reading high-contrast black letters on a white wall in a brightly lit room isn't the whole story of human vision. Real-world vision involves contrast, sensitivity, night driving, glare. And this is where the LUO study gets really fascinating regarding higher-order aberrations.
Yeah, this is the nuance that matters to the discerning patient. The ICL group showed significantly less induced spherical aberration and coma compared to the SMILE group.
Let's break that down for a second. Spherical aberration and coma are those subtle distortions that make light smear, or they reduce your contrast sensitivity in low light. Why does the laser induce them in the first place?
When you reshape the cornea with a laser, you are altering its natural asphericity, its prolate shape. You are essentially flattening the central dome. That change in geometry naturally induces aberrations. With an ICL, you are leaving the cornea absolutely pristine. You aren't touching the asphericity at all. You are correcting the light path internally.
So the physics suggests that for high prescriptions, the optical quality of the ICL is technically crisper because it preserves the natural corneal shape.
Theoretically, yes. Yeah. And according to LUO, clinically as well.
However, I do have to play devil's advocate here. It's not all sunshine and perfect optics. The study did note a specific visual disturbance for the ICL group, didn't it?
It did. Halos. The central port, by definition, creates a diffraction pattern. It's just physics. Light hits the edge of that 0.36 millimeter hole, and it bends.
So patients are seeing rings around streetlights at night. Is that a deal breaker?
For the vast majority, no. The brain adapts. Neuroadaptation is an incredibly powerful thing. But interestingly, the LUO study showed that SMILE patients also experienced halos, just from a totally different mechanism. For them, it's the transition zone, where the laser treatment ends on the cornea.
So you aren't necessarily escaping night vision artifacts by choosing the laser. You're just trading one type of physics for another.
Precisely. But there is a specific cohort where the choice seems really obvious based on this data. If you have thin corneas or irregular topography, you simply cannot safely subtract tissue.
Or dry eye. That is the other major factor we really need to flag here. Laser refractive surgery severs corneal nerves, which disrupts the feedback loop for tear production. The ICL spares the cornea entirely.
Right. If a patient already has dry eye pathology, the additive route is objectively safer for the ocular surface. You aren't severing the nerves that tell the eye to lubricate itself.
Okay, speaking of safety, let's pivot to the controversy that usually stops people in their tracks when they research this. The cell count panic. If you go on any forum discussing this surgery, the #1 fear isn't pain, it's endothelial cell loss.
And it is a completely valid biological concern. The corneal endothelium is a single layer of hexagonal cells on the inside of the cornea that literally pumps water out to keep the cornea clear. They do not divide, they do not regenerate. If you lose them, they are gone.
And if the count drops below a certain threshold, usually around 500 to 1,000 cells per square millimeter, the cornea swells, it turns opaque, and you are looking at a full-blown corneal transplant.
Correct. So the underlying fear is, does this foreign object sitting in the eye slowly rub or kill these cells over time?
We have a meta-analysis by KS and their team that looked specifically at this. They crunched the numbers from 18 different studies.
Yeah, and the KS meta-analysis found a mean endothelial cell loss of about 3.84% over roughly 21 months.
Now, hold on. 3.84% sounds high if you compare it to the natural aging rate. Yeah. I mean, we naturally lose about 0.6% of these cells a year just by existing. If I lose almost 4% in less than 2 years, isn't that a massive acceleration of aging?
It sounds alarming if you assume it's a linear progression, but the data shows it absolutely isn't. The loss is entirely front-loaded.
Meaning the damage happens during the actual surgical event itself.
Exactly. It's the surgical trauma, it's the microscopic incision, the fluid dynamics during the insertion of the lens, the instruments entering the anterior chamber. The analysis shows that after the first 3 to 6 months, once the eye recovers from that initial remodeling phase, the rate of cell loss completely stabilizes.
So it returns to the normal physiological baseline.
Yes. It drops back to paralleling that normal aging rate of 0.6% per year.
So it's basically a cover charge of cell loss to get into the club, but it's not a recurring monthly subscription cost that just drains your account over time.
That is the perfect analogy. The verdict from KS is that the long-term safety profile is highly acceptable. And the central port actually helps here too.
How so?
Because it ensures those exact endothelial cells get the glucose and oxygen they need from the steady aqueous flow. Stagnant fluid is terrible for endothelial health. The AquaPORT keeps the river flowing, so to speak.
Okay, so safety hurdle number 1 is cleared. Now, safety hurdle number 2, the vault.
Ah, yes, the Goldilocks problem.
This is the distance between the back of the ICL and the front of the natural lens. The Way study on 10,000 eyes makes it crystal clear that this space is the single most critical variable in the entire surgery.
It really is a game of microns. If the lens is oversized, the vault is too high. It pushes the iris forward, closing off the drainage angle. That leads to acute angle closure glaucoma, which is painful and extremely dangerous for the optic nerve.
And if it's too small?
If the vault is too low, the ICL sits directly on the natural lens. That mechanical friction disrupts the metabolism of the lens capsule, and you get an anterior subcapsular cataract.
So surgeons are aiming for this tiny sweet spot. The literature, specifically the Thompson Review, cites 250 to 750 microns as ideal. That's roughly half a millimeter of clearance.
And in the Way study of 10,258 eyes, the complication rate was incredibly low. But when they did have to go back in for an exchange, meaning swapping the lens out, it was almost exclusively a sizing issue.
Which leads us to the biggest technological shift mentioned in the Thompson paper. How are surgeons actually measuring this space? Because for years it felt like they were essentially just guessing based on external landmarks.
They're using white to white. They would measure the visible horizontal diameter of the cornea from the outside, literally taking a digital caliper or a topographer to the outside of the eye, and then using regression formulas to guess the size of the space inside.
Which inherently assumes that everyone's exterior anatomy correlates perfectly with their interior anatomy, that the size of my windshield tells you the exact size of my dashboard.
Which we know is just false. Scleral thickness varies wildly. The ciliary muscle placement varies. The correlation is weak at best. The Thompson Review highlights the massive shift towards sulcus-to-sulcus measurement.
Using UBM, right, ultrasound biomicroscopy.
Exactly, or anterior segment OCT. These specific technologies let doctors see right through the iris and measure the actual physical anatomical space where the lens is going to sit.
So instead of measuring the shoebox to guess the shoe size, they are finally just measuring the foot.
It seems so obvious in retrospect, but the technology to get high-resolution imaging behind the iris is relatively new in widespread clinical practice. The data suggests that direct measurement of the ciliary sulcus combined with newer AI-driven sizing formulas is drastically reducing that low vault risk.
And that improvement in predictability is perfectly mirrored in the U.S.-specific data. We have to talk about the ALBO study here.
This one is crucial because the U.S. FDA is notoriously strict. The EVO lens was available in Europe and Asia for years before the FDA finally gave it the green light in March 2022. The ALBO study is the largest single-center retrospective analysis since that approval.
They looked at 225 eyes. What did they find regarding that predictability in a U.S. cohort?
The results were genuinely staggering. 99.3% of eyes achieved 20/25 vision or better.
99.3%. That is statistically almost everyone walking through the door.
And perhaps even more importantly, there were 0% major adverse events. No vision-threatening complications, no cataracts, no glaucoma, no pupillary block.
That is a very bold claim, 0%. It implies that in a commercial U.S. setting, with U.S. surgeons who are essentially new to the specific EVO model, the safety profile completely held up.
It confirms that the learning curve is quite short, likely because the surgical technique is similar to previous implant models, but the safety features of the device itself, namely the central port, are doing the heavy lifting to prevent complications.
So we have established it's highly effective, it's safe, and the sizing tech is getting exponentially better. But is it the only option? The Van Ho review mentions a competitor, the IPCL.
Right, the implantable phakic contact lens. It sounds very similar, but there are key material science differences here. The IPCL is made of a hybrid acrylic material, whereas the ICL is Collamer.
Is that just a cost issue? I know acrylic is generally cheaper to produce.
Acrylic is cheaper to manufacture, yes. But the IPCL allows for larger optical zones. Because it's lathe cut, they can truly customize it. So if you have a patient with massive pupils who works as a truck driver at night, you can make the optic zone significantly larger to completely eliminate the risk of edge glare.
And the Van Ho study also mentions a diffractive option for presbyopia, right, for reading vision.
This is where IPCL is really pushing the boundaries. They have a model that acts like a multifocal contact lens, helping older patients read. The EVO ICL doesn't quite have a direct equivalent in the U.S. market that functions purely like that yet.
However, we really have to look at the track record when evaluating these.
Oh, absolutely. The ICL is the behemoth in this space. We're talking over 2 million implanted lenses versus a much, much smaller number for IPCL. We know exactly how Collamer behaves in the eye over a 20-year time span. Acrylic inside the posterior chamber has a very different history, and some researchers argue it has a higher potential for an inflammatory response or synechia, which are adhesions where the iris sticks to the lens.
So it's the trusted brand with the massive safety data set versus the customizable challenger. But ultimately, looking at all these sources today, Luo, Wei, Kizil, Albo, it seems the strongest argument for ICL isn't just the crisp vision, it's the reversibility.
Yes, the ultimate safety net.
It's largely psychological, right? If I get LASIK and something goes wrong or I get a weird aberration that I hate, I can't just put that corneal tissue back. It's been vaporized.
Correct. But with an ICL, as the Wei study clearly showed, if the sizing is somehow wrong or if the patient is unhappy with the halos or, and this is key for younger patients, if they develop normal age-related cataracts 30 years later, you can explant it.
You literally just take it out and the eye returns essentially to its exact pre-surgical state.
Exactly. Even if the complication rate is tiny, and we know from Albo and Wei that it really is, knowing there is a physical undo button drastically changes the risk calculus for a patient. It lowers the psychological barrier to entry.
So let's bring it all home. What does this massive data dump mean for you, the listener, who might be tired of your glasses fogging up or dealing with dry contacts?
I think the data is clear. The EVO ICL, with the central port, has effectively solved the major historical safety concerns, namely those induced cataracts and the need for that extra iris laser procedure. The studies independently confirm it offers high-quality vision, potentially even crisper than laser surgery due to less aberration induction.
Specifically for high myopes or those with thin corneas?
Yes. If you have a -8 prescription, AIDSIC is pushing the limits of safety. ICL is completely in its element there.
And with the rapid advancements in sizing technology, moving from basically guessing with external white-to-white calipers to directly measuring the internal anatomy with UBM, the Goldilocks issue of the vault is becoming less and less of a clinical problem.
Precisely. We are seeing a real maturation of the technology where the safety profile is stabilizing at a very, very high level.
Which leads me to a final provocative thought for you to chew on. We have spent decades, literally centuries in medicine, refining how to subtract tissue from the human body to fix it. We cut, we burn, we remove. But here we have a technology that simply adds.
It is an incredibly elegant solution when you frame it like that.
Right. As internal sizing tech becomes perfect and the safety data set becomes absolute, are we approaching a future where adding technology to the eye becomes the default standard of care and subtracting healthy tissue becomes the old-fashioned way of doing things?
It raises a really profound question about the integration of biology and technology. If the synthetic component is more stable and predictable than altering the biological tissue, maybe addition is the only logical step forward in refractive surgery.
Definitely something to think about the next time you are poking your eye to put in your daily contact lenses. If you enjoyed this deep dive into the data, please subscribe to What the Study Says.
And share this channel with a friend who is tired of squinting at street signs at night.